Ladies and gentlemen, welcome to the 32nd online meeting of our foundation. Today's meeting is about infection and antibiotic resistance. History tells us that for centuries, humans have been trying to treat infection by various methods without much success. It was not until 1928 when Alexander Fleming discovered the miracle drug penicillin that paved the way to cure most infections. He discovered the drug quite accidentally when a fungus called Penicillium notatum fell into a culture plate of Staphylococcus that he had been growing and had left it uncovered. He found bacteria-free zones of Staphylococcus wherever the fungus touched the growth plate. This discovery was the start of a modern miracle to cure infections by a drug. Mass production of penicillin by pharmaceutical firms followed very soon. During 1947, when India was being divided, a large section of the population suffered terrible injuries. This led to serious infections, and the Canadian Red Cross stepped in to help. They donated a large consignment of penicillin to India. It was received on the 17th of October 1947 by the then Health Minister. This was when penicillin first came into India. The word antibiotic was first used by Selman Walkman, a Ukrainian-American microbiologist. The French word antibiotique is derived from the Latin word bioticus, meaning life. Introduction of antibiotics to treat infection is nothing but a modern miracle. During the last 50 years, it has saved millions of patients around the world from certain death. However, today, the effectiveness and easy access to antibiotics have also led to their indiscriminate use, resulting in the emergence of resistant strains of bacteria. The World Health Organization has classified antimicrobial resistance as a widespread serious threat that is happening right now in every region of the world. In 2019, global deaths attributable to antimicrobial resistance was estimated at 1.27 million. I'm sure Dr. Nambi, our speaker today, will tell us more about this emerging problem. Dr. Sendur Nambi is a senior consultant in infectious diseases at Apollo Group of Hospitals and Child Trust Hospital in Chennai. He graduated from Stanley Medical College in 2002 and did his MD in General Medicine at Kilpauk Medical College. He then became a fellow of the National Board in Infectious Diseases in 2012. He is certified by the Royal College of Physicians in UK in infectious diseases and is also a postdoctoral fellow in infectious diseases from Dr. MGR Medical University. He is a governing council member of Infectious Diseases Society of India and a member of Infectious Diseases Society of America. He has published over 60 articles in journals, contributed to many chapters in textbooks, and has taken part at several international conferences. He has completed 4 important clinical studies and is now involved with 4 ongoing studies, including Tactic E, multi-arm therapeutic study in the pre-ICU patients admitted with COVID-19. I got to know Dr. Nambi closely over the last year. I found him to be a perfect gentleman who will spend time with his patients explaining everything clearly and clearing all their doubts. At the end of his talk, please feel free to discuss anything related to infectious diseases and antibiotics. I will now invite Dr. Nambi to present his talk. Over to you, Dr. Nambi.
Very good evening. Thanks for the kind words of introduction. Thanks for the opportunity, Dr. Badri. And then antimicrobial resistance, that's the topic that I've been asked to speak on. And gone are the days where we could prescribe antibiotics without even thinking about whether it would work or not. And in this day and age, irrespective of the continent that we practice, antimicrobial resistance is a problem that we need to deal with. And this is one of those profound statements made by Florence Nightingale way back in the 1850s during the Crimean War.
She advocated pure air, water, efficient drainage, cleanliness, and light as the cornerstones of good health. I don't think there could be any other better statement than that with respect to public health. Before the advent of the antimicrobials or anti-TB drugs, if you look into the tuberculosis treatment in the past, it was just exposure to sunlight, fresh air, and high protein diet. And this is one of those famous observations in Vienna by Sir Ignaz Philipp Semmelweis, where you had the two labor wards, the labor ward 1 manned by the doctors and labor ward 2 manned by the nurses. The labor ward manned by the nurses had a lower mortality. The puerperal sepsis rate was lesser in the labor ward 2. When he was trying to analyze why this was happening, he did make an observation that the doctors who were conducting labors in the labor ward 1 were also posted in the forensic laboratory. So they had at times done the autopsy, and then they had come to the labor ward straight. Those days, the concept of the hand being the source of infection was not there. Even if you had seen the word malaria had come from mal air. So it was thought as an airborne infection. So that is why you had mal air, which turned into malaria. So he proposed that the hands of the healthcare workers or the hands of the doctors who were doing the autopsies, they carried some germs from there and they had transmitted to the mothers in the labor, and that contributed to the puerperal infection. Next slide. So those days, we didn't have any complicated antiseptics. What he did was made all those doctors clean their hands with lime and water. When he did that, the maternal mortality in the labor ward 1 came down to the level in the labor ward 2. And this is a simple observation where he postulated that hands of the healthcare workers do play a significant role in transmission of germs in hospitals between patients. And those days, no one kind of took his words seriously. In fact, he was housed in a mental asylum for many years. And then the credit for this finding came much later after his death. Next slide. Antibiotics are wonder drugs without any doubt. And if you look into the impact that a simple antibiotic like sulfa and penicillin has done, this is data from the US looking into the pre-sulfa penicillin mortality for around 1 lakh population. It was around 250 to 300 for 1 lakh population. With the introduction of sulfa and penicillin from the year 1940s to 1950s, the mortality had come down from around 250 to 300, around 70 to 80. And that drastic reduction happened with just the simple sulfa and penicillin. The medical technologies in terms of advancements that we have, it would be the newer antibiotics, the procedures that we do, the surgeries that we do. And if you look into that graph, it quite clearly shows that it is all about nothing has made that impact that two simple molecules have done in terms of reducing the number of deaths. And that's the power of antibiotics. Next slide. And it just goes without saying that the number of bacteria that we have in our body is actually greater than the number of cells that we have in our body. If we look into the gut bacteria alone, we have around 10 to the power of 12 bacteria sitting in our gut, whereas the number of cells that we have is just 10 to the power of 11. So this is taking only the gut microbiome. So we have more bacteria than the number of cells. The diversity of bacteria that we have in us is actually much more than the diversity of cells too. At times, our body is composed of more of bacteria than the cells that we have. We need to keep that in mind when we are going to give antibiotics, because it is going to have a profound effect on the normal commensals, the colonizers that we have in our body that are pre-existent since birth. Next slide. So when we prescribe an antibiotic, we need to remember that there is a complex interaction between 3 different living genomes. If I prescribe paracetamol or diclofenac or aspirin or phenytoin, it is just the compound and the human host. Whereas when we prescribe an antibiotic, there is always complex interaction between 3 different living genomes. We have the human genome, then we have the pathogenic bacteria within us, plus we have the commensals. So this kind of complex interaction does not happen with the use of any other class of drugs. Next slide. So antibiotics remain the only class of drugs that lose efficacy over time. So in spite of its impact on the mortality, all drugs, all antibiotics, all have limited shelf life, because this remains the only class of drugs that is kind of used to take control of another microorganism. So there is always repercussions from the antimicrobial or the microbial world to thwart the antimicrobial efficacy of antibiotics. Next slide. This man, when he discovered penicillin during his Nobel laureate lecture, very clearly said, the time may come when penicillin can be bought by anyone in the shops. Then there is a danger that the ignorant man, or it could be the ignorant medical professional, who may easily underdose himself on by exposing the microbes to the non-lethal quantities of the drug, make them resistant. So he knew that the moment penicillin was discovered, penicillin would go off. And if at all, if there is one thing that would drive the antimicrobial resistance, is the use of drugs per se, or use of drugs at a lower dose. And this man very clearly stated in his Nobel laureate lecture regarding the doom of penicillin. Next slide, please. So that's fine. And this is a very interesting study from India, which again tells the problem of antibiotic use in India. India has one of the highest growth rate for antibiotic market. It is around 7%, which is one of the highest in the world. And when looked at the prescription patterns in the Indian capital of New Delhi, they found that even for a simple problem like common cold, 47% of patients insisted on antibiotics from the practitioners, and around 50% of the patients did self-medication with a course of antibiotics. And in that, 1 in 4 did not complete the course of antibiotics. And for common cold, 70% of doctors prescribed antibiotics, and 50% of the chemists have dispensed antibiotics without prescription. So the problem is multifold in a country like India. Patients take antibiotics on their own, chemists sell antibiotics, doctors prescribe antibiotics even for common cold. So there's a problem at multiple levels in our country. Next slide, please. So why there are so many mistakes? Because there is a high number and complexity of drugs, higher number, complexity of the clinical syndromes and the pathogens. And if you look into it, it is very easy to protocolize the management of acute myocardial infarction, or a patient with seizures, or a patient with stroke. What applies to Mayo Clinic or what applies to a hospital in London will apply to a hospital in Chennai or New Delhi for managing a patient with acute myocardial infarction, acute stroke, neurovascular accident, or with respect to the management of seizures or epilepsy. Whereas with respect to antibiotic use, it is very difficult to set up a uniform protocol that will apply to this whole world. Or even setting up protocols for a vast country like India is going to be very, very difficult because there is a constant change or dynamism in the field of microbiology. Since we give medicines to kill the organisms, there is always an equal repercussion from that microbial world. As a result, setting up a uniform protocol with respect to antibiotic use is a huge task, and that's a huge problem in training with respect to antibiotic use. Next slide, please. And this is again with respect to the global antibiotic consumption. If you look into the map, the darker red, the maroon, it means that the country or the zone has consumed more antibiotics in the last decade. The so-called BRICS nation, let it be Brazil, South Africa, India, China, have kind of doubled the antibiotic consumption when compared to the European nations, United Kingdom, the North America. So the developing countries like India, South Africa, Brazil, China, they have consumed more antibiotics in the last decade. And when there is consumption, antimicrobial resistance is bound to follow. Next slide, please. I'm not sure if all of you are familiar with this terminology called NDM. NDM is New Delhi metallobutylactamase. That is a carbapenem resistant mechanism. So we have a carbapenem resistant mechanism. The enzyme is named after the Indian capital. This was spotted in a patient from UK who came for an orthopedic surgery in a hospital in New Delhi way back in 2008 and 2009. And when she went back to the UK, they found that she had an E. coli which was resistant to carbapenems. Carbapenems were considered, like drugs like meropenem, were considered the ultimate drugs in the management of gram-negative infections. But they had a patient from UK who came on a health tourism, picking up this carbapenem-resistant E. coli and then going back to the UK. And the world had named this carbapenem resistance mechanism the name of the Indian capital, NDM, New Delhi metallobutylactamase. This was way back in 2008-9, and that created a big political furor, saying that how can something be named after the Indian capital? But that's how these enzymes are named, and that name of the NDM, New Delhi metallobutylactamase, still holds true. Can we go on to the next slides? And this is one concept that we need to be familiar with the use of antibiotics. The broader the spectrum of drug that we are going to use, there is always going to be an ecological adverse effect. That is something called as collateral damage. There could be selection of drug-resistant organisms, and these drug-resistant organisms, the patient gets either colonized plus or minus infection. If you're going to use carbapenems, drugs like imipenem, meropenem, then you're going to breed multi-drug resistant Acinetobacter baumannii and multi-drug resistant Pseudomonas aeruginosa. The Pseudomonas aeruginosa and Acinetobacter baumannii, these are gram-negatives which are typically fueled by the use of carbapenems in ICUs. There are certain countries in the Europe, per se, for example, Greece and Italy, they have high resistance for carbapenems among the gram-negative, and Acinetobacter and Pseudomonas, which is drug-resistant, is quite common in Greece and Italy, and so is the Asian subcontinent. Whereas in the UK and the Europe, and other parts of Europe and the US, the incidence of drug-resistant Acinetobacter is slightly on the lower side. But nevertheless, if you're going to have a drug-resistant Acinetobacter, the obvious driving point for that is the use of carbapenems, the use of meropenem. Next slide, please. We look into the deaths attributable to antimicrobial resistance, and we are in 2024. What is the projection for the year 2050? Antimicrobial resistance as a single entity will kill more people than cancer, will kill more people than heart attacks, will kill more people than strokes. Why? Because antimicrobial resistance will cut across all specialties. It would cut into general medicine practice, orthopedic practice, oncology practice, transplant medicine, gynecology, pediatrics. It is a kind of a single horizontal which will cut across multiple specialties. So if you're going to look into the projections for the death contributed by antimicrobial resistance per se, it will be the single biggest driving force behind deaths another 10, 15 years from now on. Next slide. So what do we have? So how do we are going to combat these antimicrobial resistance? One thing is quite clear. Antibiotic use drives antimicrobial resistance. So we have to carefully use these antibiotics. So the concept called antimicrobial stewardship, this is a kind of a key buzzing word in the last decade in almost all accredited hospitals in India, plus the UK, Europe, and the US. Antimicrobial stewardship refers to careful and responsible management of antimicrobials. That's it. You need to use antibiotics with caution and care. Next slide. So the simple question is, when you have a patient with fever, you ask yourself this question: does my patient have an infection or not? Next slide. No infection, no antibiotic. So if you think the cause for fever in your patient is not an infection, then you're not even going to think in terms of an antibiotic. Next slide. So if you're going to think of a bacterial infection, then you need to give antibiotic. A very common example for fever in hospitalized patient is phlebitis or the IV infusion. So you have to think before writing antibiotics. Does my patient have infection or not? If you think there is a bacterial infection, then think about antibiotics. It's as simple, but unfortunately, in clinical practice, it is not that as easy as it sounds. Next slide. So the bottom line of antimicrobial stewardship program, which is at times called antimicrobial stewardship AMS or ASP, the question that a clinician needs to ask is, does my patient require antibiotics? If so, what is the right drug? Then if you figure on the right drug based upon your diagnosis, clinical laboratory radiology, based upon the local epidemiology, you choose the right drug at the right time, I give it the right dose for the right duration. So these are the 4 R's that concerns the science behind the use of antibiotics. Give the right drug at the right time, at the right dose, and for the right duration. But the most important question to answer is, does my patient require antibiotics? Next slide, please. So the goals of antimicrobial stewardship would be is optimizing the clinical outcomes of the patient and minimize the unintended consequences of antibiotic use. Let it be the toxicities, selection of pathogenic organisms. Of course, the secondary goal would be to reduce the healthcare costs, because antibiotics, especially the newer generation antibiotics, are much more costlier than the older generation antibiotics like ampicillin, gentamicin, erythromycin. They are much, much cheaper in terms of the cost, whereas the newer generation antibiotics would anywhere cost 10 to 20 times more than the older generation antibiotics. Next slide, please. So you could have multiple components of antimicrobial stewardship. The key here is education, formation of guidelines and clinical pathways that should cater to that country's needs. At times you can have antimicrobial order forms. Then there is a concept called de-escalation. What is de-escalation? Is you start with a much broader drug, and once you know what you are dealing with the patient and your patient is getting better, you have cultures saying that the drug may not be required for the identified pathogen. You can use a much simpler drug, then you come down or narrow down the spectrum, and that is called de-escalation. And at times, whenever possible, change the IV antibiotic to the oral formulation. Next slide, please. This is one example of an antimicrobial order form. So, for example, in our hospital, we have a select list of antibiotics in that antibiotic formulary, which is in that restricted formulary. The clinician is free to use these drugs, but he needs to fill out this form regarding why he is using this antibiotic. Is it an empiric use? If it is an empiric use, yes, your patient is sick, you have started the antibiotic. Then at 40 to 72 hours, you have to review that antibiotic use based upon your cultures and clinical progress. And this kind of intervention is one way of streamlining antibiotic use. And this is one such form that is in our hospital. It has been in work for the past 12 years with a lot of success, which creates awareness regarding the antibiotic use. Next slide, please. This is one area where we could come down on the antibiotic use. Universally, for clean and clean contaminated surgeries, antibiotics, when given as prophylaxis, surgical prophylaxis, all you need is one dose of the antibiotic within 60 minutes prior to the surgical incision. At the most, you can stop antibiotics given as surgical antimicrobial prophylaxis for clean and clean contaminated surgery at 24 hours. You don't need to give antibiotics for preventing infections in clean and clean contaminated surgery for more than 24 hours. This is one area where, if it is implemented properly, we can minimize or reduce the antibiotic consumption. The recent World Health Organization guidelines also reiterate that stop antibiotics at 24 hours for surgical prophylaxis. And that is a kind of a boost for countries like India to follow and minimize the use of antibiotics in our surgical patients. Next slide. The germ is not important. The terrain in which it is found is much, much more important. If you look into a hospitalized patient in ICU with a central line, with a tracheostomy tube or a ventilator tube or an abdominal drain or a drain from a surgical site or a urinary catheter tube, the moment the drains are in place for more than 48 hours in a hospital, let it be the ward or the ICU, drains do get colonized with pathogens or microorganisms. At times, the endotracheal culture may grow some organism. The urinary catheter tube may grow some organism. That is not important. The key point to ask ourselves is, am I treating a pneumonia whenever I look into my endotracheal culture? Am I treating a urinary tract infection when I look at my urinary culture report? You can have more than 1 crore organism sitting in the catheterized sample, but the patient may not have an infection because of that. So colonization is quite common, especially in hospitalized patients who have all these kinds of lines and tubes sticking out of them. So the germ is not important. The terrain on which it is found is much more important. That is where the clinical skills and judgment of the treating clinician becomes very, very important. This is one area where all over the world, where cultures are done unnecessarily, as a result, resulting in a lot of antibiotic use. Next slide. There are IEC activities. IEC is information, education, and communication. All these activities have been started by the Indian government probably 7 to 8 years ago. Unfortunately, many activities have not been sustained and consistent. But in the last 1 year, there is a mandate by the central government to have a state antimicrobial stewardship program. If you look into it, Kerala is in one state in India, which is kind of a forerunner in the antimicrobial stewardship program. In fact, Kerala is one state, the last 1 month, has implemented very strongly that no one can purchase antibiotics from the pharmacy without a dated prescription from the registered medical practitioner. And that has been in vogue in Kerala for the last 1 month with a lot of success. Unfortunately, pharmacies do dispense in other parts of the country. There are Schedule H drugs being dispensed without prescription. But Kerala is leading the way in our country with respect to implementation of antibiotic dispensing from the pharmacies. And they have made it very clear that at any place in Kerala, you cannot get an antibiotic without a dated prescription from an RMP. Next slide, please. Look into the impact of vaccines. So vaccines are a wonderful resource, just like the way sulfa and penicillin can minimize the mortality or reduce the mortality. There is something else which has had a profound effect as good as sulfa and penicillin. One is vaccine, other one is clean water. So clean water and vaccines have had an important impact on the mortality. Next slide, please. Influenza vaccines. If you look into it, it is a routine practice in the UK, US, and some of the other European countries where influenza vaccine, or which is commonly known as a flu shot, has been made mandatory. I'm not sure if the NHS has made it available for all the eligible citizens, but this is one vaccine which really helps people with underlying cardiac problems, people with underlying lung problems. And one shot every year definitely reduces their hospitalization rate for pneumonias. And another thing is when someone with a cardiac problem or a COPD or an emphysema or a bronchiectasis, when they develop a viral infection, they always go in for flood of all these underlying lung problems, landing in ICU. There is one sure shot way that you could prevent these hospitalization is one thing, looking at taking influenza vaccine. So vaccines prevent infections. Vaccines prevent viral infections. As a result, the infection does not happen. You're not going to use antibiotics. It's another way of minimizing antibiotic use. Next slide, please. This is a very interesting piece of information. This is with respect to a bacteria by name pneumococcus, which is a captain of death with respect to elderly. Number one cause for community-acquired pneumonia. Number one cause for community-acquired meningitis. There is a vaccine which prevents invasive pneumococcal disease as well as community-acquired pneumonia. It's a kind of an underestimated pathogen. If you look into the mortality of invasive pneumococcal disease and community-acquired pneumonia over the decades, starting from 1952 to 1990, one of our medical advancements that we have had over the decades, it has not had any impact on the mortality of invasive pneumococcal disease. Yes, you have better diagnostics, better medicines, better healthcare facilities. Has it translated into any kind of impact on the mortality with respect to invasive pneumococcal disease? Definitely not. The mortality rate with invasive pneumococcal disease has remained around 10 to 15% over n number of decades. So what it means is don't let pneumococcus happen. Prevent pneumococcus from happening. So if you want to prevent invasive disease as a result of pneumococcus, let it be pneumonia with bacteremia, community-acquired pneumonia, or it could be meningitis. The best thing that one can do is taking the pneumococcal vaccine, pneumococcal conjugate vaccine, followed by the polysaccharide vaccine. Next slide, please. And this is quite clear. So if there is a way that we could prevent something from happening, we need to focus on that. When meditating over a disease, I never think of finding a remedy for it, but instead a means of prevention. Louis Pasteur quote. And if you look into it, again, it goes back to the Florence Nightingale thing. Focus on clean water, clean air, focus on good food, nutrition, focus on vaccines. If you're going to do all these things, definitely the infections are going to come down. The infections are coming down. You're not going to use antibiotics. Next slide, please. Yeah. So is there any alternative to antibiotics? That's a kind of an exciting field because antibiotics come with a limited shelf life. There are experimental therapies like use of bacteriophage, bacteriocins, or predatory bacteria. You have another bacteria that goes and kills the pathogens, or it could be vaccines, immunomodulatories, probiotics, prebiotics. This is an exciting area. Probably the way ahead would be with respect to the use of immunomodulators in the management of sepsis or severe infections, resistant, difficult to treat infections. Bacteriophage therapy is kind of gaining momentum in the US, and other concepts like bacteriocins or predatory bacteria are all way ahead, but it is out of common man's reach at this point of time. The focus has to be on prevention of infection and minimizing the use of the antibiotics. Next slide, please. This is with respect to recurrent antibiotic use. Someone with incessant diarrhea, and you're going to do a colonoscopy, this is a finding that you have, and that is pseudomembranous colitis because of Clostridioides difficile. And next slide, please. And when you have Clostridioides difficile infection, which is not settling with antibiotics like metronidazole, oral vancomycin, fidaxomicin, what is treatment right now is the use of donor feces. And this is a kind of a situation which we have created for ourselves. So we have used antibiotics to that level that the gut commensals have completely been knocked off. The useful silent Clostridioides difficile kind of multiplies in huge numbers, resulting in this kind of pseudomembranes formation. To replenish the gut bacteria, donor feces is used as a treatment in patients who have Clostridioides difficile and who do not respond to the routine antimicrobials. And this is not something, this is something kind of well evidenced. And this is a kind of practice in many of the US hospitals. Next slide, please. And I know that organ transplants are a kind of a fancy word. Let it be cardiac transplant, lung transplant, bowel transplant, kidney transplant. But the current buzzword with respect to transplantation is fecal microbiota transplantation, FMT. There are two pills available in the market, and the donor feces get filtered out, screened for pathogens, and the concentrated form of the donor feces is used as a treatment in patients with Clostridioides difficile infection who do not respond to the routine antibiotics that we use. And that's a kind of situation right now that we are in. Next slide, please. The focus in hospitals should be on hospital infection control. And that is a very important area which we cannot choose to ignore. We need to have the administration infrastructure geared to minimizing the spread of infections within the hospital. We need to focus on horizontal infection control measures. We need to have bundles to prevent hospital-acquired infections. If a patient has got a urinary catheter, we need to have a set of interventions that has to be put in place. You bundle up a set of interventions to prevent that urinary tract infection, and that is called bundle to prevent up a hospital-acquired infection. We need to focus on antimicrobial stewardship, environmental cleaning and disinfection, hand hygiene, and of course, education and awareness. These are very important areas that a hospital should focus on if you're looking at minimizing infections and the antibiotic use. Next slide, please. Antibiotic use is not something that you would see only with the hospitals. There is a lot of antibiotic use in the veterinary world, animal husbandry, poultry world. And this is one kind of a small study in broiler chicken in Netherlands that they found, you could see that they have antimicrobial resistance germs found in that broiler chicken meat. And it has been found. You got all the classes of drugs, starting from tetracyclines, the beta-lactams, cotrimoxazole, phenolone, resistant E. coli found in the broiler. And there is a huge market, parallel market, where in the field of animal husbandry, poultry, there is a lot of antibiotic use. They are used as growth promoters to kind of boost the growth of these artificial food that we consume. Because a normal chicken takes around 6 to 9 months, whereas a broiler comes up in 4 to 6 weeks. So a lot of stuff has been pumped into it to grow. There's a lot of antibiotics used. US as a country has recognized that as a problem, and they kind of banned certain use of antibiotics in the poultry industry and animal husbandry. The whole world is yet to catch up with the concept of focusing on minimizing the use of antibiotics in the animal husbandry industry. But that's an important area that we need to focus if you're looking at tackling antimicrobial resistance. Next slide, please. I think this is my last slide. So you can just keep pressing, Dr. Badri. If you have a pathogen, next slide. You have an infection, next slide. Keep pressing. Any infection results in antimicrobial use. Next. If you're going to use antibiotics, then you're going to have antimicrobial resistance. That is inevitable. Next slide. So when you're going to have antimicrobial resistance, a susceptible pathogen will become an antimicrobial resistant pathogen. This is a cycle that we cannot prevent. So what we need to do, next slide, we need to prevent infection. That's the most important thing. Focus on the basics: food, air, water, vaccines. That's the most important thing there. Hospital infection control. The focus has to be there. Next slide. You need to focus on effective diagnosis and appropriate treatment. If the infection has occurred in spite of our preventive measures, focus on effective diagnosis and treatment. Next slide. Optimize the use of antibiotics. You need to have antimicrobial stewardship program. For example, the measures taken by Kerala government with respect to the antibiotic use in their state is one measure which would really put a hold on unnecessary antibiotic use. Next slide. We need to prevent transmission of these infections. So when you look into preventing infection, effective diagnosis and treatment, optimizing the use of antibiotics, and then preventing the transmission of infections. Next slide. Perhaps what we have antimicrobial resistance, we may be able to put in a hold on that, or probably convert a resistant pathogen to a susceptible pathogen. Next slide. That's my last slide. Again, I'm taking a quote from Alexander Fleming. That would be my take-home message. I know that probably you guys know it, and then you belong to that generation which can have used drugs with a lot of caution. But this guy said very clearly, penicillin should only be used if there is a properly diagnosed reason. The properly diagnosed reason could be clinical, microbiology, radiology, whatever it is, but you need to have a reason why we use penicillin. And if it needs to be used, use the highest possible dose for the shortest time necessary. And that's a key concept. If you want to use an antibiotic, use the highest possible dose for the shortest time necessary. Otherwise, antibiotic resistance will develop. I think that's my last slide. I profusely thank Dr. Badri for running the slides for me. I apologize that I couldn't connect from my laptop and I had to do it from my mobile. Off to Dr. Badri.
Thank you, Dr. Nambi. That was a clear message to everyone, particularly the younger generation, to tread carefully when antibiotic is being used. There are a few medical students today, and I hope they will spread the message among their friends and colleagues. I now open the meeting for others to discuss. Thank you.